So today's class is about the normal liver anatomy, okay? And there are a lot of variations. There are a lot of small things that we need to take care when we are dealing about liver anatomy. And in this class, we'll discuss the CT anatomy of the liver segments, and we'll also discuss the variations in the hepatic veins, portal veins, hepatic artery, and bile duct. Okay, so we'll do a brief overview of the variations, and in-depth variations we'll do when we do respective sections. So today's class will be on liver anatomy. And in the next class I'll discuss liver transplant imaging. Okay, because liver transplant imaging is a totally different topic than the rest of the hepatobiliary system, and it is not really related to a lot of pathologies that we read in hepatobiliary system. Okay, it is more connected to the anatomical aspects of variations, what to report in a liver transplant patient, and this transplant imaging is very specific to liver transplant centers. Okay, and so not a lot of hospitals have a proper format of how to do a transplant imaging workup. And so this is ask A in your question form in your final MD exit exams. B, if you do join corporate hospitals, which are doing a liver transplant, they're very specific about what you have to include in your reporting format. Okay, so we'll cover this in the next class. Now, starting with today's class, we know that liver has a dual supply and its predominant blood flow. Okay, this is very important, has a lot of clinical implications. Predominant blood flow is from portal vein. How much blood flow? Around 75% of the blood flow to the liver is through portal vein, and only 25% is through the hepatic artery. So we have a dual blood supply, both of them giving oxygenated blood. Okay, and this portal vein supply to the liver is via the gut. Okay, so the blood flowing to the intestine comes to the liver through the portal vein via the superior mesenteric vein, the inferior mesenteric vein, and the splenic vein. And so this also results in transgression of number one, gut bacteria, gut microbiome, and secondly, gut toxins. Okay, and that's why we know that in amoebic colitis you get amoebic liver abscesses also, and a lot of gut toxins can also cause some associated abnormalities in the liver. Now, this dual blood supply is also very important in cases of portal hypertension. Okay, in cases of portal hypertension, we know that the portal pressure in the portal vein is high, and there can come a time when the blood flow in the portal vein is centrifugal or away from the liver. So if in portal hypertension, blood flow in portal vein is centrifugal, in that case the predominant blood supply to the liver is via the hepatic artery. In such cases, hepatic artery undergo hypertrophy. So is hepatic artery hypertrophy an indirect sign of portal hypertension in a background of liver cirrhosis? Yes. And in fact, if you do work in a liver center that like I do, you'll frequently see that in cirrhotic patients, the hepatic artery is, very hypertrophied, very big. So this is a direct correlate from this knowledge. So number one is that liver has a dual blood supply and it has a single outflow in the form of hepatic veins. Hepatic veins, there is a single outflow which drain into the IVC. Now, this particular information is important in cases of HVOTO or Budd-Chiari syndrome. Okay, HVOTO stands for hepatic vein outflow tract obstruction. Now, the third important point regarding the liver anatomy is that Apart from an inflow, apart from an outflow, there is a third system known as a biliary system, which drains bile into the gut. Okay, so these are the three important channels that go through the liver. Okay, and these three variations are what are clinically important whenever we are reporting a aberrant liver anatomy. Okay, now coming on to the liver segmentation, how do we divide the liver segments? So there are two type of classification. One is a morphological classification and another is a functional segmentation. Now the morphological classification that we read in anatomy. Okay, so in anatomy, what did we read? That the falciform ligament divides it into the left lobe and the right lobe. But forget that, that is never going to be used clinically or surgically. What we are concerned about is number one, surgical segmentation. And then related to this, we have our radiological segmentation. Okay. Now, each segment, we'll discuss how we divide the segments. That each segment we know has a separate inflow, that is hepatic artery and portal vein, a separate outflow, that is a hepatic venous radical, and a separate biliary drainage, that is a separate biliary radical associated with it. Okay. Now, surgical segmentation is done with the help of a line known as a Cantley's line, which you have read in surgery during your NEET PG preparation. Cantley's line, and tell me in the comment section from where to where does the Cantley's line run? From where to where does the Cantley's line run? Tell me. I've already shown you in the next slide also. So from the IVC till the gallbladder fossa, the Cantley line was running, and it helps surgeons to identify which structure underneath. Cantley's line corresponds to what underneath? It corresponds to the middle hepatic vein. Okay, and radiologically, this middle hepatic vein is the most important structure that God has created for liver transplant. Okay, God created right RHV, LHV for something else, but he created MHV so that liver transplant can be done. Now, through this MHV, we divide liver into the right and the left lobe. So as you can see in this segmentation, there are three planes. One plane is through the right hepatic vein. This is the right hepatic vein. The second is through the middle hepatic vein, MHV. And the third plane is through the umbilical plane, that is the falciform ligament. This is the third plane. Now, the middle hepatic vein divides the liver into the right and the left lobe. So, middle hepatic vein divides the liver into the right and the left lobe. The right hepatic vein divides the liver into anterior and the posterior segments. So, RHV divides right lobe into anterior and posterior segments. Okay, so look at this image here. These are the anterior segments. These are the anterior segments, and segment 6 and segment 7 are the posterior segments. Okay, so tell me, when the surgeon opens up the abdomen, which segments form the right hepatic border? Segment 5 or 8 or segment 7 and 6? Which segments form the right hepatic border?